You're listening to Healthy Discussions, a podcast supported by the Healthcare Leadership Academy, where we have conversations exploring big ideas in healthcare with our guests. I'm Zack Hassan, a junior doctor from Scotland. If you're interested in how we can make the health system better, then this is the podcast for you. On today's podcast, I'm talking to Dr Lade Smith, Director of Forensic Services at South London and Maudsley Foundation Trust and 2019 Psychiatrist of the Year. We discussed how criminality and mental illness can be traced back to adverse childhood experiences, the need for early intervention, and the role doctors should play in changing policy and preventing discrimination. I hope you enjoy. Lade, welcome to the podcast.
Thank you for having me, Zack. Thank you.
So I'm really glad you could join us because, you know, a forensic psychiatrist that works in intensive care, like that's objectively a really cool job. And I was just wondering, how did you get into that?
So I became a consultant for the Brixton area, and when I became a consultant in 1999, we used to run a ward and also have a community team. And essentially, actually, if you work in Brixton is a very, particularly at that time, it was a very busy area, lots of mental health problems, lots of deprivation, and it meant that essentially, and also it's a high crime area as well. So essentially that kind of qualifies you to become a forensic psychiatrist, essentially. But after that, I then went and ran the intensive care unit, psychiatric intensive care unit at the Maudsley Hospital. And I did that for quite a few years. And during that role, we developed quite a few innovations, actually, because I'm very much into the idea that, you know, if you can, you want to try and avoid people becoming highly disturbed and violent. And that's the reason why they're in intensive care, because their mental health problems had resulted in them becoming aggressive and, you know, potential risk to others. But the idea that we had was to try and help people so that they didn't become so aggressive that they would hurt other people. So a lot of the work was really focused on trying to intervene before things got to the stage where someone ended up being aggressive and having to be restrained, etc. So we did a lot of work around that. And then I was asked if I would go and help out at the Forensic Intensive Care Unit, which was this is for SLAM, South London and Maudsley, and that was based at the Bethlehem. So I went over to help for a few weeks and ended up staying for a long time, actually. But and in fact, actually, I don't do that job anymore. I've handed that over to somebody else because now I'm the clinical director of the service. So
I see. So you've kind of progressed from doing that job into sort of more of a leadership role, kind of directing the services. So, yeah. I mean, what was your average day like when you were actually, you know, doing that job in the forensic intensive care? What is that like day to day?
That's an interesting question. An average day. There wasn't an average day. Never, ever, ever boring. We never did the same thing twice, other than, you know, there would be the ward round and there would be a management round and there would be, you know, the kind of daily rounds, things like that. But really every day was quite different because, you know, it's very much about, you know, what people's needs were. And so it's responding to people's needs, anticipating people's needs. You know, it was exciting. There was always a bit of drama. It was at the extremes of emotion, I would say. Actually, there was. It's interesting because people always think, "Oh, think about psychiatry. It's kind of sad," but there's a lot of happiness and there's a lot of joy, especially when you've got someone who's extremely unwell. And one of the good things about being at the high end of psychiatry and the acute end is that people are extremely unwell and then they get better after a few weeks. And when they're well, they're really well, and it's really rewarding. So you really get to see that shift and that change in a way that you don't see quite so readily in more rehab psychiatry, rehabilitation psychiatry, where the shifts are made, but they're much they're smaller and slower. So you don't quite get the, the kind of the more instantaneous rewards that you might get in acute psychiatry.
And from my experience in sort of working in adult hospitals, just as a ward doctor, kind of my main involvement with the psychiatrists is like involved in decisions about detention, basically, and is this person's mental health condition bad enough that we need to keep them in hospital against their will, or compel them to be treated. I'm just interested to know how much a part of your job that is in forensic psychiatry, and what are the differences about forensic psychiatry working in the sort of with the justice system.
Sure. So actually a very similar thing happens. In fact, we have to think very carefully about people's liberty, actually. And of course, a lot of our patients have come to us via the criminal justice system, but there's a whole heap of other ones, but probably about a third of our patients at any moment in time who've actually come up from general services. And we know that anyway, about 74 to 75% of our of patients in forensic mental health services are actually graduates from general mental health services. And then on the wards, quite a significant proportion are detained under civil sections of the Mental Health Act as opposed to criminal sections of the Mental Health Act. So those decisions about whether or not a person should be detained in the first place, and then subsequently whether they should be discharged or whether their detention should be renewed, are made all the time. And when it comes to forensic mental health, of course, you've got the additional input of, in the first instance, the courts, and also the Ministry of Justice. And in fact, I see a lot of patients now who have been referred from prison. So a lot of the things I have to do is go and assess them and decide whether or not that person has got a mental health problem that means that they need to be transferred from prison to hospital. So I don't think people always realise that you can't forcibly treat someone to, if they've got a mental health problem when they're in prison. Prison is just like being in the community. And if you're in the community and you don't want to, you're unwell and it's felt you need to take treatment, and you have it's thought you don't have capacity, then it might be like, okay, we think you need to come into hospital for treatment. It's the same thing for prison. So we do a lot of that, actually.
And just the way that you were kind of talking about, why you went into it and you're kind of wanting to intervene, something that interested me, made me want to invite you as a podcast guest, was that part of what you seem to be saying was that a lot of the causes which leads your patients to, require treatment are actually happening long before they get to you. And I was wondering if you could talk a little bit more about what you meant by that.
Yeah, so certainly by the time we see patients in forensic mental health, it's usually they've been ill for a while, and actually most importantly, the things that result in people coming into forensic services, i.e. having contact with the criminal justice system or having some kind of issue around violence, etc. Problems that are usually to do with trauma that has happened much earlier in their lives. So they're often people who my patients are often people who've had in their childhoods, they've had emotional abuse, emotional neglect, huge amounts of emotional neglect, physical abuse, sometimes sexual abuse, and so these adverse childhood experiences have shaped their development, and they've often grown up in difficult environments, actually. With parents or caregivers who just weren't enough for them and neglected them, or, as I say, abused them. Hasn't been helped by the school situation because their problems haven't been noticed at an early age. They've kind of dropped off the conveyor belt, if you like, of life at a much earlier stage than you might do normally. By the time they're in their early teens, they're using street drugs very regularly. That increases their risk of developing mental health problems as well. They end up kind of falling foul of the criminal justice system very early, oftentimes. And they're people who you look at them, you sort of think, you know, if I'd met you when you were 3 or 4 years of age, you might have been able to help you divert from this trajectory into forensic mental health. And increasingly, I've been thinking that our job as doctors and psychiatrists, it's not enough just to treat the illness in the person.
To treat what you see in front of you.
Yeah, we really need to start thinking more and more about, because if you really want to make a difference, you've really got to start advocating for better support at a much earlier stage. Because the truth is that the costs in terms of the individual's personal functioning, so they're not going to achieve their potential in terms of their, educational functioning and their individual social functioning is huge, right? So they're just not going to achieve their potential. They're not really going to have an enjoyable life for the most part. The cost in terms of wider society is enormous as well, because people that I look after are much more, obviously they fall foul of the law, which means that somebody has been harmed in some way. The patients I look after, generally it's because they've behaved in a violent way to somebody else or someone else's property. Mm-hmm. And then the cost, and if you really don't care about these people and what might happen to them, there's the actual cost of it. Because these are people who are young adults. The cost of them looking at, the cost of them just being in care is huge. And, so for example, cost of someone coming into hospital as an informal patient is, it's a few £1,000s. It's about, I think something like I think the cost of community care generally is about £2,000 a year. The cost of someone having an informal admission, it's probably about maybe double that. The cost of a formal admission, involuntary admission under a civil section, is about £18,000. The cost of detention under a forensic section is in the conservative region of about £350,000. So
that's more than the median salary, isn't it?
Yeah, that's way more than the median salary, actually. And so what that tells you is that if you can do something to intervene, if you can intervene at a much earlier stage, so even if you were to divert 10% of people away from forensic mental health care, then the cost would be enormous. And we see our patients sort of think, yeah, we could have, if only we'd met you when you were younger, or if only we'd been able to surround you with services in the community, say when you were 17 or 18, if only when you were at school, when it looked like you were this naughty kid and you were about to get excluded, if only someone had realized that actually this person's got some major emotional difficulties, and if only they'd been surrounded at that point with interventions, then you wouldn't have ended up in forensic mental health care, costing huge amounts of money. And also, of course, if you're a young adult, just like you are contributing to society, and you will, you contribute to society with the kind of job you'll do, but also you are going to pay lots of tax at some point, probably now, and carrying on paying lots of tax. And so all that missing revenue to, the coffers of society is problematic. So, it's a huge cost in terms of personally, clinically, societally, and it's costly financially as well.
So what you were talking about there, it sounds like there's multiple causes that are racking up here, as people are going through childhood and early adulthood. And by the time they get to you, there's already been so many kind of missed opportunities. I'm just very aware that a lot of these patients are coming into contact with multiple services. I'm wondering, do you see any understanding, in the justice system or the education system, like, hey, wait a minute, if we exclude this person, we're actually denying them maybe support that they're needing, or if we give this person a custodial sentence, maybe we're denying them the chance to get treatment for something that's going to become much worse later. Is there that understanding, or is there a balance there?
I'm not sure that there's a systemic understanding of that. I'm pretty sure that if I were to talk to the individuals who work in each of those systems, there would be people who would say similar things to me. But the systems that we have in place currently are not really working for these people that we're looking after primarily. And certainly the school system isn't really working for them. And, the criminal justice system, I think probably the criminal justice system, there's pretty good diversion, if you like. But you could argue that by the time someone's in the criminal justice system, it's already a bit too late.
Mm-hmm.
So I mean, particularly with the people that we look after tend to be, they're young men, basically, primarily. And by the time they come to us, it is a bit, you sort of feel like it's a bit too late now. And what we have to do is hope that because we're in the kind of the business of secondary and tertiary prevention. So, this is what people don't realise. By the time they come to us, the deed has been done. Whatever it is that's happened for them to come to us has happened. And we need to try and make sure that they are well enough and have enough understanding of their problems for it not to happen again. The difficulty is that, we can give people medication and psychology and occupational therapy support, and we can help them with housing, etc. But the foundations that mean that they are in a trauma, they've had trauma that has shaped how they respond to other people and how they respond to institutions and various authority, etc., has already been, it's been going on for years. And so there's something about the institutions and the structures that need to change to reduce the likelihood of these people having being in the position that they're in, that it means that they end up meeting people like me, actually.
And so you kind of talked a little bit about kind of what a good outcome is in those circumstances. It's about, preventing things getting worse, preventing maybe, reoffending, preventing kind of worsening of their mental health. I just wonder what patients themselves kind of say about these institutional factors. I'm especially interested in that because there's a kind of balance between taking the patient, at face value and then also kind of seeing what they're saying through the context of, well, we've sectioned you because you don't have capacity to make your medical decisions. So I'm interested to get your insights on that.
So I'm not sure that the patients really say much about, they wouldn't necessarily say anything about, the reason I'm here is because, my school was rubbish, and they didn't notice that I was, emotionally neglected and traumatized when I was young. That's not really what people say. You ask them and they'll tell you that, school was a bit difficult and I was expelled when I was 11, things like that. And you say, wow, what, you were expelled? Really? What did you do? And they'll say, well, I used to get into trouble and things. But they don't necessarily understand. Why would they? When you're the 11-year-old kid, you don't necessarily recognize that.
You don't join all those dots.
No, you don't. You don't recognize that actually it's not okay for an 11-year-old child to be excluded. And if there's a problem with an 11-year-old child, then actually it means that the problem is what's surrounding them, and that there isn't the sufficient support. My patients definitely, our patients definitely complain about the institutions that result in them being sectioned. And, as you all know, there's plenty of complaint about the mental health system and it being unfair, and particularly, there's disproportionate detention of Black people, particularly in the higher end of care. People complain about access to mental health care at an earlier stage. They complain about the experience they have when they are in mental health services. And we know that outcomes are poorer for Black people as well. So there's lots of complaints. People don't like to be detained. Why would they? No one wants to be detained against their will.
If that's all you've ever known, then you're not going to think that it's abnormal. You're not going to think that you've grown up in an abnormal environment. It seems like you're thinking about all these. Basically, the question I want to ask is, what needs to change? If you're sort of seeing the effects of this, what do you think would work in terms of addressing some of those problems?
Do you know, that's a good question. I think one of the difficulties is that just in the way that if you've grown up in a difficult environment, that's just what's normal for you, right? And just as, my patient, you don't get it, Dr. Smith, this is just how it is. In much the same way, people who are in positions of power, I think some people just think, well, this is just how it is for these people, isn't it? This person grew up in a deprived area, and deprived people have rubbish lives, and it's their own fault for being deprived somehow. The reality is that the person who's in the deprived position is in a state of impoverishment. And I don't just mean that they're poor, I mean that they are poor in terms of not having a voice. They are poor in terms of not having power to effect change in their own lives, unless they've got some incredible talent, like, they're a brilliant footballer and they're lucky enough to have gone to some football scheme when they were 8 and some person spotted that they're a brilliant footballer, and lo and behold, you've got Marcus Rashford or something like that. But most people don't have that, and it's not fair that if they're in a position with little power, that someone who's in a position of power should not then make the effort to try and change the structures that mean that those people who are in this position of deprivation and impoverishment and marginalisation, that those people aren't supported. So to my mind, it's incumbent upon those who are in power, and that includes doctors. Doctors often don't realise that we're in positions of power. It doesn't feel like it, especially when we get dictated to and stuff like that in our work. But the fact is that we are in positions of power and we can make a change. And of course, there are people in positions of much greater power than us who are policymakers, who can make a difference in terms of the policies that are changed. And what doctors can do is advocate for patients. We can do huge amounts on an individual level, but we can, certainly with my patients, it doesn't matter how brilliant a psychiatrist I am, unless my patient, if I treat my patient and then they go back to exactly the same kind of environment that, with poor housing and, they don't have enough money and scrimping and scraping, etc., as before, then the outcomes are going to be the same.
So you've given them a sticking plaster, but not actually kind of addressed what injured them.
Exactly. So there's something about advocating for systemic change to reduce the likelihood of these worse outcomes in the long term. And increasingly, I think that if you talked to me about this 20 years ago, I wouldn't have said this, but with that, I'm absolutely sure now. Part of what our job should be as doctors, and certainly in mental health, but I'm pretty sure in most medical specialities, really, part of what we should be doing is actually advocating for systemic change, so that there are fewer fewer people coming with poorer health. Simple as that. I mean, if you look at poverty level, poverty is associated with poor health, full stop. Poverty is associated with obesity. Poverty is associated with worse outcomes when people get cancer. Poverty is associated with greater infant mortality. So it's pretty, you can be the best doctor you want to be, but actually a better thing would be to lobby, your local MP, so that they can do something to reduce, to make sure that there are policies that mean that there's slightly less poverty, so there's going to be fewer poorer health outcomes.
I see. So you're really seeing this as kind of coming from very upstream. There needs to be, action outside the healthcare sector on a political level to try and address some of these kind of root social causes. I want to come back to something you said about the kind of the inequality, the race inequality and the wealth inequalities in the prison system, and I want to know about. I just want to understand a bit more about where is that discrimination happening? Is it happening inside healthcare or outside healthcare, or is it more in one place than another place? Where if we wanted to kind of focus on a priority, where would that be? Where do we start working on this problem?
Wow, that's a good question. So discrimination is a societal problem. I know that some people would like to think, oh yeah, it exists just in that person, or it just exists in that institution. That's not true. We know that there are various types of discrimination, and it's born out of prejudice. Discrimination is behaviour that's associated with prejudice. Mm-hmm. Everybody has prejudice, and everybody has there's individual prejudices, and some people meet them out against others, and they discriminate against other people for whatever reason, because of their race or because of their sexuality or the gender, whatever. But that kind of individual discrimination is not this it's important, but it's on an everyday level. It's not the thing that really makes a difference to the disproportionate rates of detention and mental health care, or in healthcare, for example. There is structural discrimination and institutional discrimination. And that happens in all that structural discrimination is, it's in the historical structures that we have in our society. So that's not just about mental health care. That's not just about healthcare. That's society, full stop. There are institutional discriminatory factors that happen within the different institutions. And collectively, those institutions, unfortunately, end up upholding some of the structural discriminations that we see. And so it's funny because there's lots of focus on mental health care, because it's really obvious in mental health care that there have been this disproportionate rates of detention in the Mental Health Act. And that's been highlighted because of the Mental Health Act review that I was involved with. And but it's interesting that I think, actually, because psychiatry is perhaps one of the more it's one of the more scrutinized branches of medicine. It means that people have to really reflect and think much more carefully. And it's probably, I think, one of the least racist bits of health, actually. If people are really going to look very carefully at obstetrics and gynecology or cardiology, I think what you'd find is that there are significant discrepancies in healthcare experience and outcomes there too. In fact, we see it in obstetrics, where if you're from a BME background, if you're black or brown female, you are much more likely to die in childbirth in the UK. I mean, that's just something like 5 times more likely to die in childbirth. That's just incredible. What's that about?
And is that explained by any other factors like wealth or the kind of educational attainment, or do we know that race is a kind of independent factor in that, or is it just something that we need to explore a bit more?
So the thing about race is that race isn't independent of wealth, certainly not in the UK. And it will also say ethnicity. And the problem is that people often lump everyone together as though being black or brown is a homogenous thing, and it's not. We know, for example, that if you look at South Asian people, if you are from an Indian South Asian background, then you're likely to be just as rich, if not richer, probably, than a white British background. If you're Bangladeshi, if you're South Asian person from Bangladeshi background or Pakistani background, then actually your levels of wealth are really quite low for some of the poorest people in the country. If you're Bangladeshi or you're black Caribbean or black African, you're really unlikely to own your own home. And whereas if you're Indian South Asian, you're much more likely to own your own home, just as likely as a white British person. So you can't separate those. You can't separate those factors, actually. The question really should be more about, why is it that certain types of brown people, certain types of black people are much less likely to have money, are much more likely to go to a rubbish school, much more likely to be in poor quality employment, or much more likely to be unemployed. And oftentimes people try and say, well, it's individual factors. It's just because you're not, good enough, or you're not, you're too lazy, or whatever it is. But it's just not as simple as that. There are undoubtedly some structurally discriminatory factors that make it harder for certain groups of people to progress in life. And those structures that keep people marginalised, work to continue to marginalise people. So
Mm-hmm.
people are less likely to have a voice. If you have less money, you have less power. You have less power, you have less of a voice. Simple as that. You can't influence governmental policy in the same way. So, for example, you have equipment, you have the podcast, you're able to. You've got a voice. You've got some say. That's if you don't have this equipment, you don't have the kind of education, then you have less of a say. Simple as that.
And and that's part of why I wanted to make the podcast, because I've been thinking, there's lots of issues that you see in the healthcare system. As a junior doctor, you don't always feel able to do very much about them. So why not kind of use some skills to try and at least make a start, or at least talk about the issues. So that's kind of that really hit home for me. I want to ask you just one more thing about this kind of point about discrimination, because I think my assumption sort of coming into this topic was thinking that discrimination is going to be one way. It's going to be kind of right where they're going to be locking up more ethnic minority people. They're going to be diagnosing them more with mental illness that they don't have. So I was really interested to see in the mental health review that you were part of, that part of why or something that you were critical of was that a panel had kind of not detained somebody who was sort of deemed to be a risk because they were afraid of appearing racist. And I was wondering if the discourse in the UK at the moment around politics of ethnic identity is you know is there a kind of a kind of counter racism of kind of the wrong decisions being made because of appearing to be racist, and that's actually hurting the patient at the end of the day.
So just to be clear, that was something that was discussed years and years ago. So I think that statement was made. That was when I was on the ES1. So that would have been like 2005, 2006.
So quite historic.
That's historical, and things have changed a lot since then, and people have a lot better understanding. So that was in the days when, certainly long before COVID and George Floyd, and in the last, even before that actually. But what we know now is that everyone has a better understanding about, I hope anyway, about systemic factors that engender discrimination. And a lot more people have done the reflecting and reflecting on their own levels of discrimination, and that's everybody actually, and their own understanding of the structural discrimination in the world in which we live. What it means is that people have been better able to own their their innate prejudice that they might have, and to work through it a bit better. And it's a journey, and everyone's at different stages of the journey. Historically, people could only, couldn't even begin to voice that. They would either be a racist or not. Simple. What they were not able to understand are the nuances and the different types of racism and stuff that we have better. Well, it's just been publicised more, so people, I hope, have better understanding of that than they used to. I mean, lots of people still don't get it, and even people in our government don't really get that, and say all sorts of things that are just not really that helpful. Is there? I mean, I think what happened then is less likely to happen now, because I think that people are more likely to take advice actually, and to think a bit more carefully about why it is they're making their decisions. And I would hope that was a particular panel, but there we go. They react. I mean, I'm sure there are still panels who would just react very carefully. Would be worried that they might be seen to be racist if they didn't discharge someone. But I think I hope that there will be more nuance in their thinking nowadays.
I'm really heartened to hear that you think things have changed in that regard. So That gives me some reassurance. So what can we do as doctors? You spoke about us having a voice and having power. And I'm just thinking, what can we, do as doctors with our careers? Is it about trying to address some of the evidence gaps? Is it about trying to be more aware of our own bias, or something else that you see as important?
All of the above. First and foremost, be the best doctor you can be, actually, and know your stuff as best as possible. But good doctors recognise that we don't know everything, and that you're never going to be able to learn everything. There's always much to learn. Good doctors recognise that the person sitting in front of them is an individual and doesn't make judgments about them based on the way they look, and finds out about that person. And also good doctors recognise that people live, if you get to know an individual, then you'll learn about the context within which they live. And if you understand better about the context within which a person lives, then you understand better about what treatments are going to be more beneficial and how that person can respond to that treatment within the context of their lives. So there's no point, if you're an orthopedic surgeon, you fix someone's hip, you think that's the best job I've ever done, beautiful, fantastic. But actually, the person lives on the 6th floor of a council block, and the lift doesn't work ever. Then the fact is that getting the physiotherapy they need, and ensuring that the work that you've done continues to that their hip heals appropriately, that's it's not going to happen in the same way as if they live in a nice leafy house and they've got access to private physiotherapy and all the rest of it, blah blah blah. So there's something about understanding the context in which people live, and then also when you have the opportunity, talking to your social care colleagues and your local authority colleagues, and actually trying to influence local policy so that it better benefits the patients that you look after.
And as a clinical director now, do you feel like you've got access to more levers to try and influence some of these things? Or, is it still, is there still a kind of sense of, not being able to control the things you want to be able to control?
Well, obviously, I can't control everything, but I certainly have more access to or more influence on the ears of people who might make a difference. So, people are more likely to listen to your advice, but also you're more likely to be in a room where there are people who you might be able to influence, if that makes sense. I think the other thing is that you don't have to be a clinical director to be in that situation. And one of the things that I wasn't properly aware of when I was younger was the importance of policy decision making. And this is just because of the way that we're trained, I suppose, or were trained, which is very much about you as an individual practitioner working with an individual patient. And it was only really been in the last few years that I've properly understood how decisions made by commissioners about the policy, local policy and national policy, has such an impact on people's health outcomes. And I think junior doctors now, I hope, have a better understanding of that, actually, and that we're teaching people more about that. And I would urge people to try and get involved in policy work and certainly understand about policy and how policy is made at an early stage. And that's, I think, something that we can start doing better in terms of training people. I know that I talk to people about policy now in a way that wasn't, my supervisors didn't talk to me about policy when I was training in the same way. And maybe because it was different, but certainly policy decisions are really important in terms of the healthcare that we deliver.
Well, I'm certainly glad that you're sort of nearer the conversations where those decisions are being made. Just coming to the end now, so I usually finish by asking if you'd like to recommend a book that was influential on you, or that you think people should go and read if they want to find more about some of the issues that we've been talking about.
the things that are going through my, funny enough, actually, things that are going through my head are actually, I was thinking about Ray Bradbury books, actually, is really, but it's probably not that, it's not that, yeah, I actually think people should read Ray Bradbury, and I think they should read some Margaret Atwood, actually, because the policy changes all the time, but what influences policy is having what's going to influence policy for the better is having a good understanding about how people treat each other and what can happen if people don't treat each other properly. And I think Ray Bradbury and some Margaret Atwood would help people to understand a bit better about how to treat people. Because I think the thing is that at the moment, I generally am always being asked about, ethnic inequality, and not so much about policy stuff. And actually, I'm glad you asked me about the policy stuff, really, because I really do think that probably about 20% of our work at least should be advocating for our patients in a policy level. And that's what I'd quite like to see, really, that that happens as doctors, and people would be like groaning, I'm sure. But if we did that, I just think it would just be better clinically, but also it'd be a lot cheaper for everybody. I mean, it really was. Yeah. It's a win-win, actually. Really, yeah.
Okay, well, thanks very much for speaking to me, Lade. It's been a pleasure.
Yeah, you're very welcome. Thank you very much for having me.
If you like the podcast, the best way to support it at this stage is to tell your friends about it and share it on social media. You can use the hashtag #HealthyDiscussions or my Twitter handle @MontereyZack to tell me your thoughts about this episode. In the description, you'll find more about our guests' work and their book recommendations. Thanks to Health Education England North East, Health Education England South West, and Medics Academy for supporting this episode. All of us at the Healthcare Leadership Academy are grateful for their support.